This is the joints unit, chapter 8 in your textbook, sorry. A joint is where any two bones meet together. They're also called articulations. Sometimes when they meet, they don't move. Sometimes they're very movable. Examples are your shoulder, your arm can move all over the place, but the bones in your skull can't. So those are the sutures in the skull. Those are immovable. So it varies depending upon what the joint is supposed to be doing. There's types of them. There's the fibrous, cartilaginous, and synovial are structural terms. Then synarthrosis, amphiarthrosis, and diarthrosis are movable terms of how they function. And now these can be a little confusing, the synarthrosis, amphiarthrosis, and diarthrosis, because they're a little ambiguous at times, and they can be multiple types of joints, except like synovial. All the synovial joints are diarthrosis, but the fibrous and cartilaginous, some of them are synarthrosis, some of them are amphiarthrosis. So it can get a little confusing about it. But we'll explain as we go. All right, again, a synarthrosis now. These are joints that do not move. Okay, and there's no movement wherever they are. They are held together by fibers. Okay, and there's three subsets. There is sutures. Like I said, we find those in the skull. Gomphosis is your teeth, where they go in and your teeth don't move. So again, that's synarthrosis, no movement. And then syndesmosis is where you have two bones together, and there's fibers between the bones holding them. And there's not a lot of movement on these, but there can be some. An example is the radius and ulna in the wrist, but you can rotate it a little bit, so there is a little bit of movement. So that's not necessarily synarthrosis, that's more of an amphiarthrosis, because it's just a little bit of movement. When the sutures in your head and your teeth, there shouldn't be any. All right. Again, they're relatively immobile. Some of them can be mobile. Like I just gave you an example. And so here they're showing you again. Now they're showing you the syndesmosis is between the tibia and the fibula in your leg. Again, there's not a lot of movement there, but you can rotate your leg a little bit also. So there is a little bit, and that would make it an amphiarthrosis. When sutures and gomphosis are, there's no movement on those two. All right, so again, amphiarthrosis means there's a little bit of movement. Two main types of these. Now these are all cartilaginous joints. These are synchondrosis and symphysis. Now these here, there's a little bit of movement in all of these. These are held together by cartilage, hence cartilaginous joints. And again, very little movement on it. Examples are, the first one is up here with the first rib, behind the clavicle. There's a little bit of movement with your rib cage and your sternum. That's why you can take a deep breath, move your arms and everything up and collapse down. And then in your spine, okay, because that's the synchondrosis. Now, if you remember back a couple of lectures ago, that epiphyseal line, the epiphysis and the diaphysis were actually two separate bones, and then they grew together as we get older. So it's easy for a young teenager to actually pop the epiphysis off of a bone, depending upon the location of it. And as we get older, that doesn't happen because they kind of fuse together. Your symphysis, this is between two bones in your back, between each of your vertebrae, and we can all bend our back forward, backwards, side to side. So we know there's some movement in there. And the pubic symphysis is between the pubic bones. For the most part, it doesn't move, but during childbirth, it will move. So again, there's just a little bit of movement on there, but there is some. So all of these are, most of these, I should say, are amphiarthrosis. But like that epiphyseal line there, the play, that one, there's really not any movement on it. So that one there would be a synarthrosis, no movement. So again, that's why the movements can be a little confusing on naming them. So go focus on what they're made of. So these are the cartilaginous joints, and the two types are synchondrosis and symphysis. Synovial joints, these are very complex, and this is what people normally think of when they think of a joint, okay? These have cartilage at the end to help cushion the impact between them. There's a space between them filled with a fluid. They have a capsule around to prevent that fluid from leaking out. There's tendons and ligaments usually around this area, lots of ligaments. All right, so here's an example. One bone, another bone. The blue right here is your cartilage. This area in here is that joint cavity, which is that fluid-filled space. It's got synovial fluid in it. It acts kind of like a lubricant. This is actually a knuckle on a finger, and when you pop your knuckles, you're not breaking anything. All you're doing is just making the capsule, the cavity larger, so there's a vacuum that happens, and that's what the popping is. It doesn't hurt your knuckles, doesn't make them bigger or anything like that. Excuse me. And then we have ligament here again. There's a ligament going from a bone to a bone. You have your capsule again surrounding all this, keeping the fluid inside of it. A few other terms. Tendons. This is a collagenous tissue. It's a connective tissue that connects a muscle to a bone. Okay. A ligament, on the other hand, attaches a bone to a bone. So I'm going to back up a slide. Again, there's a ligament right here. We're not showing any muscles, but this one's attached to this bone on the periosteum, and this was attached to this bone on the periosteum. Then we have a bursa, and that's that fluid-filled sac on the inside. These kind of act like ball bearings to help, they'll roll to reduce friction. A tendon sheath is basically, it's a bursa that instead of being like a ball inside of a joint, these wrap around tendons to prevent friction from happening on them. They'll roll on the tendons. You'll see the pictures coming up. Types of synovial joints. These are complex. We got a ball and socket, two locations, your shoulder and your hip. Condylar, these are in your fingers and your wrists, right through here. Saddles on the thumb. Planes are in your carpals and tarsals. They're good for sliding, moving your hand back and forth. Hinge, elbow, and knees are the best ones for that. Then pivot. So up at the top, you're between vertebrae 1 and 2. We can turn around, we can pivot our head. And again, like I said on the wrist, we can pivot the wrist. So that's where we're talking about with the elbow. This is the radioulnar joint right here. So again, examples. Yeah, here's the plane showing you down here on the carpals, and they slide. It's a slide, gliding is what they call it. It's a gliding movements. Okay, these are in carpals and tarsals. Then again, you have a hinge joint. Elbow and knee are the best examples. Notice on the elbow, they're only showing it with the ulna. They're not adding the radius to that because the radius is technically is a pivot point where the radius rotates around. So that's what gives you rotation. Here we have flexion and extension. We haven't got to those yet, but we'll get to them. Types of movements. A condylar is on your fingers. These give you quite a bit of range, so you can go back and forth. You can go do a circle with it, all different kinds of movements. So that's why it's a biaxial movement. They're pretty mobile. A saddle joint, this is only at the thumb, okay? Again, lots of movement on it. Go back and forth, forward, backwards. You can do a little circle with it if you wanted to. Again, pretty mobile. Ball and socket, so the shoulder and then the hip. These are the most mobile, movable joints. These can move in any direction. They give you some things: flexion, extension, adduction, rotation. We'll cover all those terms in a little bit. But those are your 6 types of synovial joints and the movements that go with them. All right, so now let's focus on these movements. We always start from zero position. So think about that anatomical position where you're standing straight, palms facing forward, feet flat on the surface. A flexion from that position is the decreasing of any angle. So like your arm, when you flex it like that, so you decrease that angle, that is flexion. Extension would take it back out. Now, if you happen to go beyond normal, the zero positioning, we call that hyperextension. Some people can do it with their double jointed, but it's not really double jointed. They're just a little bit more mobile, a little bit more movement in their joints. And we have these in lots of different examples of these. So here we go. Flexing of the L of the shoulder here. They move it forward, so they're decreasing this angle. They bring it back, so that would be an extension. And then hyperextended, they took the L of the arm, because it should be right here at midline, and they took it past it, so that's hyperextension. Remember, because flexion moved it out, extension brought it back. Same with the leg. Flexion, extension. Abduction is in the frontal plane. Now remember, frontal plane is where you divide it into front and the back, so we're moving along that plane, so it's going to be a sideways movement. All right. Abduction. When you abduct something, you take it away. So I'm going to stand up here. Abduction is the arms moving away. Adduction, so adding, we're going to bring it back. You bring the arm back down. We can hyper adduct because we can bring it past the zero position. All right, so again, that's the same way with the flexion and extension. Circumduction, again, going in that circle. And we already talked about the gliding on the wrist. So here they go. There's your adduction, abduction, circumduction, and there's that gliding on the wrist. We have some more specialized terms here, getting into elevation is moving anything up. Look, see, my shoulders are going up, so I elevated my shoulders, depress them, I bring them back down. I'm bringing them back down to zero positioning. Bring them down. Protraction, retraction. You can move your shoulders forward, backwards. The picture is going to come up. It's going to show you sticking your jaw out and then bringing it back. So sticking it out, bringing it back. That's protraction, retraction. Rotation, we talked about turning your head. Supination, let's stand up a little bit from that one. Change the angle of the camera a little bit. Can't see my hand. All right, so there's my hand. So this is normal. Pronation rotates like this. Supinate rotates back like that. It's the same with your feet. You know, your foot, you're sitting like this. If it rolls in, that's a pronation. If it rolls out, it's supination. They give you a few different terms for your ankles, for your feet when we get a little bit later. And that's right here. The inversion is, again, turning the foot like this. And then eversion is turning it out laterally. Plantar flexion, so your foot's like this, plantar, so you're going to be pointing your toe down. Dorso would be pointing your toes up. And opposite, really the only place we have opposite is with the thumb, because as we move our index in, or to, in this case to my left, my thumb goes to the right, so they're opposite movements. That's opposition. And here's some examples of rotations. There's more than just one. There's that supination and pronation. It happens with your feet also. And supination and pronation is a little different than this inversion and eversion. It's just talking about how you're on your foot, it would be rolling in and then rolling out for supinating. And that's different than turning it. Okay. Again, protraction, they use the jaw as the best one for that. Depression, they're using the jaw for it also. And elevation, but you can use the shoulders. If you raise them up, you're elevating them. And then opposition. All right, some of the major joints in the body that we kind of need to know a little bit about. The glenohumeral, so gleno is the glenoid cavity. That's going to be right up here at the shoulder, and the humeral. So we're talking about the arm, the shoulder, what we're talking about. It's not a very deep cavity, which gives us lots of movements, and we can do all kinds of movements with our shoulders. But because of that, because it is so mobile, we also get lots of shoulder injuries. All right. There's a labrum in there that helps stabilize it. And then the muscles and tendons around it help, and ligaments help hold it up, stabilize it also. But we don't have a lot of strength inferiorly, and a lot of times your shoulder will get knocked down, and that's where it's injured. So that's where most dislocations happen with shoulders. A few of the main things you should know: the acromion is part of the scapula, the coracoid process, again, part of the scapula, and the ligament between them, so the coracoacromial ligament. You have a subacromial bursa. There's that little ball bearing thing I was telling you about earlier. It helps for the shoulder moving. You have a coracohumeral ligament. So that's going from the coracoid process to the humerus. All right, a lot of these, if you say the names, it'll tell you where they are. So that's one thing I want you. I also want you to know this, your tendon sheath, and they're showing you the one wrapped around on the biceps. This is going to be attaching to the biceps. So that means this is a tendon, hence a tendon sheath. You have the glenohumeral ligaments, okay? And that's the ligaments right here coming from the glenoid cavity to the humerus. There's a subscapular bursa, so it's underneath, it's on the bottom, the anterior side of the scapula as we stand, all right? And those are the main things I want you to do: the coracoid process, glenohumeral ligaments, subscapular bursa, the acromion, the coracoacromial ligament, the subacromial bursa, coracohumeral ligament, and the tendon sheath. Those are the main ones I want you to know on this particular picture. We're going to dive into a little bit more, but those are the main ones I want you to know. So now if we remove the humerus, move the arm out of the way, you can see now where we have that glenoid cavity in there. It's a little pocket for it to go, the humerus to attach to. And then there's that glenoid labrum in there that helps stabilize it. Again, see, there's that acromion, the coracoid. So here's that coracoacromial ligament going between those two, even though it's all on one bone. And then if we were to take a frontal view of it, slice through it so we can see it through, you can see that bursa, you can see how it would roll. And here's the tendon sheath. So as the tendon going to the muscle moves and the bone would move up, this is sliding around, preventing friction. So that way it doesn't hurt. Friction is what's going to cause it to hurt. All right, now we're on to the humeroulnar and proximal radial joints. We're at the elbow. Again, because humerus and ulna is the elbow, and then you have the radioulnar joint, and that's for that rotation. All right, so the radioulnar ligaments restrict side-to-side movement. The radioulnar joint is, again, where the elbow provides the rotation for the forearm. It is not part of the hinge function, which is the elbow. The elbow is the hinge. This is not a hinge function. This is right there. This is not part of the hinge of the elbow. And then there's an annular ligament that wraps around the radius, the head of the radius, and holds it in place. So there's the annular ligament, and you can see it from both medial and lateral sides. It wraps around it. And again, that allows it to rotate. And then you have your radial collateral ligament and your ulnar collateral ligament. All right. Those hold the elbow in place and keep it from keeping the elbow from moving side to side. The coxal joint, coxal is hip. All right, so this is where the femur meets the acetabulum, which is kind of like the glenoid cavity of the hip. All right, this is where the head of the femur holds most of the body weight. And if you hear of somebody falling and breaking the hip, or somebody breaking the hip, that's usually what it is. They're breaking the head of the femur off and not actually breaking the hip bone. All right. And if you remember looking at the pictures of the hip, it is a much deeper socket, which makes it a much stronger socket, but we don't have as much movement in our hip as we do our shoulder. So we sacrifice strength for movement, or movement for strength. Again, they've got a labrum just like the shoulder does. It's very similar to the shoulder. All right. So here we go. The head of the humerus is right here into the acetabulum, and it's this piece right here, that neck of the femur, that is usually breaks, and that's what people call a broken hip, because that's what's holding all the weight. We have ligaments that hold them together, and the ligaments are named after the bones that they attach to. So the iliofemoral, from the ilium to the femur. We have an ischiofemoral, from the ischium to the femur. This is a posterior view. An anterior view, you're going to have a pubofemoral, from the pubis to the femur. Okay, and there's the greater trochanter, lesser trochanter, and the neck of the femurs here and through here. And this is what breaks when somebody's this is usually what is broken when somebody says they break a hip. We have a tibiofemoral joint. Again, this is between the tibia and the fibula. Actually, tibia and the femur. The fibula itself isn't necessarily part of the weight-bearing portion of this. But there is a little bit going on in here. So let's go ahead and look at this. So we're talking about the knee at this point. And the knee, again, we have some menisces, lateral medial, again, depending on which side they're on, and prevent it from going side to side. We have the ACL and the PCL, so the anterior cruciate ligament and the posterior cruciate ligaments. And these are inside, and they kind of crisscross. The ACL is pulled tight whenever you hyperextend your knee, so don't do that. This is a very complex area of ligaments. This is actually the strongest joint in the body because there's so many muscles and ligaments and tendons going around it. At least 13 verses. We're not going to go into that detail with them, but there's a lot going on at the knee. So these are the menisces that we were just talking about. This would be the lateral. This is the medial menisces. This is the cushioning for it. You see them right here. There's your condyles. Here's your condyles from the femur going down to the epicondyles on the tibia. You have your fibular collateral ligament. Sometimes people will know this one as the lateral collateral ligament because it's on the outside. You'll have the tibial collateral. It's also known as the medial collateral ligament because it's on the inside of the knee. And here's that ACL and the PCL, how they crisscross inside the joint itself. Okay, so those are the main things I want you to know. The fibular collateral ligament, the lateral meniscus, where am I at? I missed one. The posterior cruciate ligament, the tibiocollateral ligament, the anterior cruciate ligament, and the medial meniscus. Then we have a patellar ligament here attaching from the tibia to the kneecap, and we have a quadricep tendon here attaching the kneecap to the muscles on the front of the leg. These are three extra things. Really focus on this right up here and over here. Oh, that's it for our unit. Those are the main, or for this unit, those are the main joints I want you to know about. Remember, go back to the beginning, know the classifications and the styles of joints there are. Take your time, review it. Good luck, and we'll see you.